Please join us in welcoming her. Lisa,
Thank
I will
you.
pass it over to you.
Thank you so much for that incredibly kind introduction. Um, Still does not feel real to have those initials behind my name. So yes, as her name said, my name is Lisa Pettit-Green. I am a recent graduate of the University of Kansas Medical School, and I will be starting my pediatrics residency in just over a week at Children's Mercy. And today I am here honored to be hosted to talk about something very near and dear to my heart as a topic of assessing and improving medical care for children in the foster system. As a just really quick overview of what I'm hoping to cover in the next 30-ish minutes, I want to discuss and kind of lay the groundwork for how we're talking about medical care for children in youth in the foster care system and bring in some recent studies on how these systems are working or not working, especially in regards to foster caregivers and healthcare providers. And then I want to talk about next steps. I think we can all agree the most perfect child welfare system would be one that didn't exist. And until that day comes, there's always going to be ways for us to improve. So, hoping to kind of start that conversation and bring to light to maybe less thought of issues within the foster care system. So, Raneem also already did a great introduction for me, but I always like to kind of lay the groundwork of why me, why I'm talking about this. I always will use an excuse to share my family. So I am a mom. I had two little med school babies. So that is my 3-year-old and my 9-month-old on graduation day for me. But prior to my two biological children and starting med school, my husband and I were foster parents for 2 years in the state of Kansas. We had a handful of long-term placements and a few respite placements. So we experienced the struggles of the foster care system firsthand in advocating for the children who were placed in our care. Because of this, I applied for and completed a research fellowship between my first and second year of med school called the Clendenning Fellowship, which is when I was connected with Dr. Heitzman Powell in this wonderful group. And it was on this topic. It was on some of these gaps in care that I saw as a foster parent and then as a medical student, kind of wanting to bridge those two parts of my life and bring to light some ways that we can advocate and improve. And then that has carried over into the rest of my career. Like I said, I am getting ready to start my medical residency in pediatrics with the hope of carrying this work forward. So, like I said to start, I just want to lay some quick groundwork about some foster care statistics. This is from the Kansas Department of Children and Families, or DCF, report for the fiscal year of 2024. There's a lot of statistics. The big ones that I want to bring your attention to are just the average. So, on average, there are about 6,000 children in the state of Kansas who are within the child welfare system. You can kind of see it fluctuates up and down, but 6,000 is pretty consistent, give or take a little bit. This graph breaks that down into what kind of placement setting they're in. So you can see that almost half of these 6,000 children are placed in a family foster home. And that means that is kind of the typical foster home that people think of when they think of foster care. So people say they're foster parents, they would be a family foster home that's licensed through the state of Kansas. Their next kind of majority is relative placement. So DCF does their best to place children with an appropriate family member or relative when at all possible. Sometimes that's not possible, it doesn't work out for one reason or another, and that is why children are placed in family foster homes. And then you can see the minorities of living on their own, group residential home, and then a small percentage are either pre-adoptive or within maternity care. Another thing I kind of want to lay groundwork for that people aren't really familiar with is foster parent training. So you do have to be quote unquote trained to be a foster parent. You have to get licensed. These requirements are not federally mandated. They vary from state to state. These are the kind of basic requirements in Kansas. So you have to be 21 or older, have some kind of income guidelines, not using any kind of state or federal assistance, be able to actually provide housing, kind of show that you can provide care for children. And then the kind of highlight of this is you get 30 hours of training. We use MAP foundations in the state of Kansas. I believe on the Missouri side, they use something called TIPS or STAR training. Very similar. It's spread out, or it can be spread out over multiple weekends. It can all be done in one weekend. They kind of vary to meet people where they are. And it just kind of goes over the purpose of foster parenting, some basics of trauma-based care, things like that. And then, you also go through a background check and then sign many agreements to not use physical discipline for children and go over some of those basic care guidelines that you are held to as a foster parent. So now that we know kind of the children that we're serving in the state of Kansas and the training, why does this conversation matter? Why does medical care for children within the foster care system matter? It matters a lot because the majority of children in foster care are going to have mental, physical, behavioral, or a combination of all three typically needs. So 80% of children who enter foster care have significant mental health needs. The number one reason for placement within foster care is neglect. So you think about just kind of the mental trauma that can be associated with that in children that just makes up a huge, huge medical need. As a result, children in foster care are prescribed psychotropic medications at a rate 3 times that of other children who are enrolled in Medicaid or who might be in the same socioeconomic demographics as them. 30 to 80% of children come into foster care with at least one diagnosed medical problem. The reason that is such a wide range, a 50% range, is because many children who come into care are either, under or completely unimmunized, completely untreated, undiagnosed, undertreated for a diagnosis they might have. They might come in with acute illnesses if they've experienced trauma or neglect, infections, burns, things like that. And then they obviously will have continued sequela for a lot of the things that they have experienced in their very short time. So it can be complicated on day one. It could look one way, and then a week into care, some of these things can come to light, necessitating more medical care. As a result of, unfortunately, all of this, about a third of children in foster care do have a chronic medical condition requiring continuing medical care. Something that I know is particularly of interest to this audience is behavioral health needs in foster care. This is a slightly older graphic, so it is from 2005. So these statistics have only increased since, but it just compares children in foster care and their behavioral health needs versus children who are enrolled in Medicaid, just kind of showing that there is a crazy increase in the divide. There is a significant amount of money more required for children who are in foster care, and they are prescribed psych meds, almost double the rate of children who are in Medicaid who are not within the welfare system. Another thing I wanted to talk about was the American Academy of Pediatrics and Child Welfare League of America establishing healthcare standards for children in foster care. So this is their suggestions for care, kind of their, the basics of what we should be providing children. Some highlights of this are the wanting children to be seen early and wanting children to be seen often. So it is highly, highly suggested, required basically, that there is a medical health screening visit within 72 hours of placement, and then a more comprehensive health admission visit within 30 days of placement, and then another follow-up within a couple months. And then they want to see children back often, like we've kind of talked about. These children have experienced abuse, neglect, have acute or chronic illnesses, all of this kind of necessitating more intense care, especially because they're in a different home, they're in a different environment, and they need to be followed. So they want to see children monthly, under 6 months, every 3 months, up till 2 years, and then twice a year for children up to the age of 21. And this all includes a mental health evaluation, a developmental health evaluation, an education evaluation if they're of age, and then a dental evaluation. So the standard, as it should be, is hitting all of those marks. But I don't know if you guys have been trying to schedule any health appointments for yourself. It's really hard to get into, for myself, trying to get into the dentist. And so you can imagine trying to schedule multiple appointments in already packed schedules can really be a hindrance to care, despite that being the recommended standard. So now we've kind of laid that groundwork. What is the current system in which we provide medical care? Anyone who's been in the foster care system might be familiar with something called the Red Book. It is exactly what you think it is. It is a literal red binder. This travels with children from placement to placement, and it is supposed to hold all of their important paperwork, including court orders for placement, background medical information, their cards, social security cards, any medical insurance cards. Again, I don't know if any of you guys have tried to keep a binder before, but not always the most consistent and easiest thing to update. It can really vary depending on who updates it, who's had hands on it, if people are remembering to put things in there. But that is kind of the current standard of how we keep paperwork and take it with. Children within the foster care system are covered under Kansas Medicaid automatically. So their caseworker, case manager is responsible for enrolling them upon admission into the child welfare system. And if anyone's familiar with Medicaid, there are 3 different plan options. So Aetna, Sunflower, or United Healthcare Community Plan, all for Medicaid in the state of Kansas. And once that's all done and all enrolled, the next step is actually taking those children to the doctor, where you get forms like this. Again, if you've ever been a parent, if you've ever been to the doctor and had to fill out one of these forms for yourself, they ask a lot of questions. Again, as a mom myself, I sometimes struggle to answer these questions for the children that I have had since birth. So you can imagine taking a binder of often disorganized information and trying to fill out these comprehensive forms about family medical history, immunizations. Does a child ride a bicycle? If it's within 72 hours of placement, what are the chances you actually know, developmentally, or some of these milestones that you might be asked about? It's kind of a clunky system. It doesn't make it easy for the parents or the doctors to have all the information they need to provide this comprehensive screening. And because of the experience that we had using this system, it led me to wonder back in 2020 how foster parents are experiencing this system. I had experienced the clunkiness myself, and I wanted to see if this was going to be, if this had been the same experience for other foster parents within the system. And this led me to pursue that study that I talked about between my first and second years of med school, where I distributed a survey. It was, I don't know if you guys remember 2020, we had a whole global pandemic going on. So I had to switch everything to a virtual survey, submitted through a couple different options for foster parents. It was sent out in email blasts through the foster care clinic at Children's Mercy, Missouri Family to Family, and then Foster Adopt Connect for Kansas and Missouri. And then I also sent a survey to pediatric providers because I wanted to see what it was like on their side. How is it kind of being perceived from both the foster parent side and then from the pediatric providers who are being given this kind of disjointed information. I was blown away by how many foster parent survey responses I got. I got 60. And I really felt that some of these surveys were people who were like, oh my gosh, I finally have the chance to talk about this gap in care, this gap in needs that aren't being met, that just aren't often the top of the list when it comes to foster parents. So the majority of my respondents were from Missouri. And this graph on the right shows how long they had been a foster parent. So the actual majority of them were about from 3 to 10 years. So they had been within the foster care system for quite some time. In the survey, I asked about their most recently fostered child, and those statistics did line up with some of those statistics I'd shared earlier. 55% had some kind of developmental or behavioral health diagnosis. 28% did have a physical health diagnosis. 18% had no diagnosis yet, but they did have needs, and 35% were prescribed multiple medications. So in the survey, one of the things I asked was training on Medicaid. You remember I touched on the training that foster parents in the state of Kansas receive. It's about 30 hours. Of the 30 hours, 75% of those 60 respondents said they received no training on any form of Medicaid, KCART during that foster care training. A couple comments that people provided, which I really felt was the kind of cathartic experience for a lot of the respondents, because they, wrote these really wonderful comments. They took the time to just share their frustrations. And I wanted to share some of those in this presentation. One person said, better training on Medicare, which I believe they meant Medicaid, and the options. I know there are 3, which I touched on, but had never seen any paperwork, didn't have a card, had a sibling set, and all 3 children were on a different plan, but they didn't know why. And then another comment that said there are no instructions that gave practical training on Medicaid. They tell you the child will be covered, but you have to find providers and navigate the Medicaid game. And I definitely experienced this myself when we were trying to get care for the children in our care. Medicaid is already hard to navigate, and if you throw in the complication of not having the Medicaid card, not knowing, which plan they're on, it can be really difficult to figure that all within that 72-hour window and try to get a child into the doctor. With these respondents, we asked them some questions about like agreeing, disagreeing. The good news is that the majority of the respondents did say they felt they had access to resources for mental health needs. But unfortunately, after that, things started to switch where they felt they didn't have resources to Medicaid or KCART, or they didn't really have training for resources of physical health needs for children in foster care. These are some other just really powerful quotes that I received in this survey. We talked about how the Academy of Pediatrics wants children to be seen within, 72 weeks of placement. And this person said some clinics won't see a child until they have their medical card. Some children have taken several weeks to get the card, and the child came to us sick, or else they came needing to be seen immediately due to suspected abuse. But if clinics won't take children without their Medicaid card, what are foster parents supposed to do? Next thing, changes to KCART, meaning insurance and providers. There's no uniformity. That kind of calls back to the sibling set that had 3 different plans, having to navigate researching all 3 of those plans and which sibling gets which coverage. And then the thing at the bottom, finding a medical provider. If you do find the medical provider, our office is accepting new patients. Our office is going to have openings within that 72-hour window of placement. And then also foster parents do a lot of waiting. There's a lot of people who there's a lot of waiting while the case managers or the caseworkers, who are also completely overworked, are trying to get all of this set up. And in the meantime, a child is waiting for that medical care. Another question I asked these parents was, do they have access to medical records? Vast majority was no. Typically, you can see here, they were not given the medical history on their foster child by a social worker, or within that red binder that was brought, vaccination history, kind of those standards that we, typically see with children, or typically asked about. And as a result, they found it really hard to answer any questions the pediatrician had for them. I don't know if they're up to date on vaccinations because I wasn't given that information. I don't have access to their previous medical records. Some more quotes. This is from somebody who said it's up to foster parents to keep on top of the immunizations appointments, but they can get missed or delayed. And sometimes there can be oversight. So this person, when they had a 2-year-old placed with them, the 2-year-old was completely unimmunized. And so trying to play that catch-up game without knowing exactly what or where or the last time they'd received something can be complicated. And then this was another quote, make sure they have parents, so family history, access to medical records. This person was placed, it was a relative placement, so they knew at least one side of the family history. But if you're placed, if you're in that 50% that is placed with a traditional foster family home, you wouldn't have that information. So these are just some more quotes. I won't read them all to you, but the kind of echoing theme with all of them is that foster parents don't know medical history. Children often won't know their own medical history. I don't expect my 3-year-old to be able to recite everything, and we shouldn't be placing that onus on children in care either. And there is just a really big gap in care of medical history, and keeping that with children and accessible to people who need to know that information. The other question I asked, like I said, I mentioned that survey for pediatric providers. I only got 5 responses. It was 2020, so we were chalking that up to the pandemic, and medical field was a little stressed out. So they actually had a wide range of practice. So some were very new, some were had been in the field for 10 to 15 years. The ones that answered, I think, did respond because they had seen a lot of children in foster care in their practice. So they also have a vested interest in improving the system. And the majority of them practice in both Kansas and Missouri. Again, we gave the survey with options to agree, disagree, and these were by far overwhelmingly statements that they all disagreed with. They didn't have access to prescription history for children in foster care. They didn't feel they were that the foster parents coming in were able to answer questions. They didn't have the vaccination history, even with our statewide immunization registry, and they didn't have previous medical records. On the professional medical side, medical records are vital for providing care. You want to know history, you want to know medication history. What has a child been on? What has a child tried before? That can really make a difference in what next steps of care are. And without that information, you kind of have to start from scratch, which can really lead to delays of care for children. We also asked them about the child welfare system themselves. Are we educating our pediatric providers on the child welfare system? Thankfully, most of them agreed or were neutral on kind of having the structure of it, but less were confident that they had specific training on the kind of the nuances of children in foster care. I know a personal issue I ran into were pediatric providers not knowing the difference between, the foster parent and caseworkers, who has the final say in approving medical care. If, the provider wants to start them on medication or wants to pursue some kind of treatment, who can say yes to that? And then we also asked questions about the office staff. A huge part of medicine is relying on, the front office staff, the medical staff, like the nursing teams. And thankfully, 100% of them agreed that they could coordinate medical care. But 100% of them also disagreed that they were notified when children were moved. So if they were moved or reunited back with their families, if they moved to different placement, these offices were not notified and therefore would have no reason to know that they needed to send medical records and they needed to update anything within their medical system. This was one quote from a physician. It's about that red binder, that red book that we talked about a little earlier. It's often disorganized, incomplete, or not present or available at the time of the visit. And sometimes foster children are sent to visits with a social worker or with a transportation worker who, again, would know very little about medical care. I'm seeing a comment. Yeah, I've had issues with providers refusing to my kids or provide me with information because release from DCF is within the past year, but the notary seal at the time is now past its expiration date. Yeah, Stephanie, it's it can be frustrating how many different layers of legality you have to jump through when you, as a foster parent or as a pediatric provider, even are just seeing the patient, seeing the child in front of you, and having a mound of paperwork that's preventing you from receiving the care that that child deserves. So absolutely, I completely forgot about the whole notary system. That's another whole conversation. So we asked pediatric providers what changes they would make to the foster care system. And they all said that they wanted centralized information. They wanted a portal. They wanted a statewide system instead of a binder where things can be so easily lost or disorganized, paper shuffles, making it just more accessible across the state, across providers and caregivers. I mentioned that this information is all back from 2020, and there's actually updated reviews from the Administration for Children and Families. So this is a federal review system. It's a two-phase process. There's a state assessment, and then that is done at the state level, so kind of the state self-reporting. And then the Administration for Children and Families does an on-site visit. And Kansas recently had theirs in 2023. So for Kansas, that on-site visit consisted of case reviews of 65 cases. So 40 of those were in foster care homes in 3 different counties, so Brown, Crawford, and Sedgwick counties over a year. Kind of an example of these case reviews. You can see this paperwork. It just asks if a particular foster care case is applicable for this assessment, which every child has physical health needs. So the answer should have been yes for all of those. And then it just asks questions like, during the period under review, did the agency adequately assess the children's physical or healthcare needs? Either yes, no, or not applicable. And so these questions, these kind of forms were filled out for each of those cases. As a result, you can see this item 17, which is physical health of a child. It has this like little algorithm of where the answers to those questions lead to whether or not the physical health of the child is a strength or an area needing improvement from a statewide perspective. So from our state assessment, which is kind of that first level of this study, you can see over here on the left is from fiscal year 2016, and then on the right is fiscal year 2022. So kind of just a continuum across the years. And I wanted to draw attention to just a couple of these specific questions that the states answered. So did the agency assess the children's physical health care needs? You can see we've dropped from 89% to 64%, when really that should be 100%. I think we can all agree. I will say for most of these statistics, you see a significant drop in 2020. Again, the pandemic, really caused a lot of backlog in the welfare system and the medical system. We've never really recovered. A second one was, during the period under review, did the agency ensure appropriate services were provided to the child to address all identified physical health needs? We dropped from 85% to 49%, so less than half of these children are getting services to address physical health needs. And then for foster care cases, during the period under review, was the agency providing appropriate oversight of prescription medications for physical health issues? And that was only 60%. So that means that 40% of these cases, the reviewers felt that there was not good oversight of prescription medications for physical health issues, which does cause a little bit of alarm bells, especially from the medical standpoint. Any medication, we want oversight with anybody, not just with children, but especially prescription medications. So that was a statewide review. And then we also had our on-site visit. So that's done by the Child and Family Services team. They kind of put them all into different well-being outcomes. So physical and mental behavioral health fall under well-being outcome 3, which is children receive adequate services to meet their physical and mental health needs. And you can see the outcome itself, just kind of the umbrella term, we are not in substantial conformity. So only 52% of the cases reviewed had that outcome marked as a strength. And then those individual items making up this outcome 63% were marked as a strength for physical health of the child, and 55% were marked as a strength for mental behavioral health of the child. And if you kind of call back to the start of the presentation where I presented some of the statistics, 55% strength for children who have or a severely increased risk for mental and behavioral health needs is kind of a scary statistic, and shows a lot of area of needing improvement. This is just a breakdown of how they kind of assess the questions they use to assess these items. And I'll draw your attention to this left column, which is the foster care performance. And you can kind of see how it's broken down, how they got to that 52%, 53% strength. So that included questions, like, did they have services to address any identified health needs, and that's only 67%. So we're getting children to the dentist at a rate of 73%, but we're treating them at a rate of 67%. This was another breakdown for that second item, mental and behavioral health needs. You can see we have, 72% assessing the mental and behavioral health, but 48% of services to treat those identified mental and behavioral health needs. So just a huge gap between identifying and actually being able to care for and provide that care needed. I see something in the chat. My county did not have any dental providers that accepted medical cards until 2021. Wow, the next nearest one, 22 miles away, no longer accepts new can-care patients. Yeah, Stephanie, again, I have felt that kind of pain myself where you might, like I said, identify, oh, I need that need, but then finding anyone who will actually treat that need is so difficult, especially when you're jumping through the hoops of Medicaid and the welfare system. And then just, there being a gap in coverage. I know a lot of, especially the rural areas, are starting to lose providers and just causing more of a backlog where people are having to look at traveling 3 hours to try to get to a city that has someone who will accept Medicaid or work with children in the welfare system. Yeah, so these are some direct quotes from that study. Essentially, the summary of these quotes is that because Kansas is a fully privatized child welfare system, so if you're not familiar with that, that means that we have different agencies that are contracted to work within our child welfare system. It also means that there are completely different systems and practices depending on which umbrella or which agency you fall under, or which agency you receive your training from, or which agency is responsible for placing a child with you. This leads to variations, inconsistencies that are revealed, that have revealed fractures in data, communication, assessments, and service delivery. And then this last quote was, there's efforts to ensure children's physical and dental needs were assessed, but there's inconsistency in children receiving those actual visits, especially dental, medication oversight, and providing foster parents with medical and dental records. And then again, just that we're getting mental and behavioral health assessments done, but actually getting services provided happened in less than half of the applicable cases reviewed, despite there being significant needs, which again is a huge source of frustration, not only for the children, but for their caregivers and for the medical professionals who are trying to provide that care. So what now? I've given a lot of information. I've kind of talked about all of these gaps in care, but what can we do about it? The number one thing that I think anyone can do, no matter where they are, if they're a foster parent, if they're a medical provider, is just continue to advocate at the state level for policies that prevent this from becoming an issue at all. So supporting families during crisis to prevent placement within the welfare system. We talk about the issues that foster parents have trying to seek care for children in care. These families are experiencing that firsthand as well. Some of those neglect removals come because parents don't know how to navigate the system themselves. And then the other thing is to increase funding for the child welfare system. We want to increase funding to allow for more training, to allow for better training. We want to increase funding within the Medicaid system to improve access to care there. I really like this graphic that just kind of shows upstream things that we can do to prevent this downstream effect that ultimately does end in foster care. Child welfare prevention within the family preservation services, improving education, things like that. So there's a lot we can do upstream to prevent all of these downstream kind of, the plugging, trying to plug all the holes in the wall. Instead, we can just try to build a stronger wall. Another thing we need to do on the medical side is implementing workflows in pediatric clinics that identify children in foster care. There's such a vulnerable population to not have something, flagging their charts, identifying, children as being at higher needs, higher risks, and also higher risk for loss to follow up. Is a very simple, solution that can be looked at and implemented on the primary care side. And then hospital systems should continue to increase training for medical professionals on how to care for children in this vulnerable population, explore options for shared EHRs, and also standardized documentation so that we're just kind of getting that layer of continuity of care regardless of where the child is being seen. So that was my presentation. Thank you all for listening. I think I'm ending right on time, which I'm very proud of myself for doing. So with that, I will stop sharing, and I'm happy to answer or discuss any other questions or comments people have. But thank you for listening.
Thank you, Lisa. If anyone has any questions, please feel free to drop it in the chat. Okay, so we have something from Stephanie. So Stephanie said post-COVID policies requiring CMHs to continue to provide services to foster children until they can get an intake with their new local CMH when they move has been helpful. But not all children are able to participate well in Zoom sessions. I have been able to get scripts written by previous providers too, since it can take months to get those transferred as well.
Yeah, and Stephanie, I think from the medical kind of side of things, I'm so glad that your providers are willing to write those scripts. Some providers who don't have that training, who don't have that background and understand kind of the welfare system, I could see being a little hesitant to continue prescribing when they're like, well, I haven't seen the child for, 6 months, not realizing, that just might not be a feasible option, that it can be difficult, especially if the child is moved to a different home or if you're having to travel 3 hours to Kansas City to be seen at the foster care clinic at Children's Mercy. It can be difficult for you as a foster parent to advocate when you need those scripts, when the child's benefiting from that, and then all of a sudden you're kind of stuck in the middle of, we're transitioning care. We don't have a new provider yet, and the previous provider is not working with us on that transition. So thank you so much for just kind of sharing your experience as well. Like I said, I have very quickly realized that what we experience is being experienced by pretty much every foster parent or caregiver in the state of Kansas. And so I'm glad that we're, getting an opportunity to kind of make some noise about it and find areas to improve.
Okay, well, I think now is a good time to share our case presentation. So this is our structure for the case presentation. The presenter, which will be me for this one, will review information about the case. The KUMC and ECHO community will ask questions, and then the KUMC team will offer recommendations and solicit recommendations from the community. Next slide, please. Okay, so this is our case. Michael is a 17-year-old with autism spectrum disorder and an intellectual disability. He has always been narrowly interested in topics, wrestling, wrestlers, Marvel movies, and characters, and talks about these topics nonstop. As he has gotten older, his hyper-focus has gotten more intense to the point that he will not engage in school or home activities. Instead, wanting to talk about these topics, watch videos on his phone about these topics, or watch the same movies over and over. When redirected to participate in an activity at school, he has become aggressive or refuses to participate. At home, he has become aggressive when not being allowed to engage in these topics and had a couple of incidents when he was aggressive with his mom when she took his phone away or when the internet was down and he could not access his content. Recently, when school directed him to engage in another activity, he eloped and left the school grounds. Likewise, he has begun eloping with his phone from home when access to his preferred topics has been threatened. Both school and home are at loss of how to engage Michael given the aggression and elopement. So with this information in mind, what suggestions do we have for this case?
This isn't so much a suggestion as just a comment. When Raneem had initially shared this with me, I was like, it feels like I'm reading the chart of a child that I have seen, on the inpatient side, which I think is, like I said, not really a suggestion, but just kind of an added layer that a lot of times these children end up being placed in inpatient medical acute care because there is no safe place, home doesn't feel like they can adequately care for them. And so they bring them to the ER and then they're put on like an inpatient hold, which is, out of their environment, kind of the worst thing that can happen for these children. So on the medical side, we often see them when they're in crisis because, as this case presentation says, school and home are a loss, of what the next steps to do are. And we understand, but then we also medically are like, we don't know what to do. We're the worst place for this child to be out of routine, out of, their safe space. So yeah, it happens a lot.
Thank you, Lisa, for sharing that. So if anyone has any suggestions, please feel free to unmute yourself or drop it in the chat, whatever makes you feel comfortable.
Has the school done a functional behavior assessment and put in place a behavior intervention plan?
They have not shared that with me yet. But would that be, Lisa, would that be a good point moving forward?
Yeah, I think a lot of times, kind of that first step is advocating, at the school level for, IEP assessments, depending, he's 17, so he's older, having maybe catching this a little earlier if possible to get kind of those assessments done or the therapies kind of started at an earlier level. Because it kind of sounds like I said, this reads to me like we're heading towards crisis, trying to intervene, which is easier said than done, through those assessments through the school to kind of get their individualized plans.
I was thinking maybe the school, similarly to the school, doing a FBA, perhaps seeing if there's a community-based provider that is fluent at conducting FBAs in a home setting so they can work in concert with the school.
Parsons dual diagnosis and training, maybe.
Yeah. Does anybody know if Parsons still has the dual diagnosis team?
As of a couple months they did. They were really, really far waitlisted out though.
Yeah. So if, but there are a couple of places that do provide those services. And then also, I'm wondering if this family could, because it's not clear if this kiddo is getting waiver services, either through community mental health or through the IDD system, in which case they could have supportive home care workers that could help. And I think on the community mental health side, like the SED waiver, if he's dual diagnosed, I think they can go and be supports at school as well.
Awesome. Thank you, Linda.